So now we are going to discuss about another important topic, which is endocrinology. So next chapter we are going to discuss is endocrinology, right? So first I will discuss about the basics of the pituitary and hypothalamus, right? Because in hormones they are usually formed and secreted through the hypothalamus, right? So see this, what I wanted to tell you. Hypothalamus, what is hypothalamus? It is present in the basal part of the forebrain, right? So hypothalamus is a structure which is present in basal part of forebrain. So basal part of forebrain will be having hypothalamus, and hypothalamus, they will contain neurosecretory cells, right? So what is this? Hypothalamus will be containing neurosecretory cells. Neurosecretory cells. So hypothalamus will be containing neurosecretory cells. These neurosecretory cells will be releasing hormones, and that will control the pituitary, right? So now, as I said, hypothalamus, they have neurosecretory cells which will control secretion of pituitary hormones, right? So that is the point we have to remember. So hypothalamus, they contain neurosecretory cells which will control secretion of pituitary hormones. How they will control? Through the neurons of the hypothalamus. So now again I will write, and so that we can understand. Again I will write hypothalamus here. So in hypothalamus, as I said, neurosecretory cells will be forming hormones. Hormones will be carried through the neuronal axons. So neuronal axon, right? So neuronal axon will transport them to the pituitary. So this hypothalamic neuronal axon will transport to pituitary gland. Transport to pituitary gland. So right now we can understand whatever hormone we are seeing released from the pituitary, they are controlled by secretions of the hypothalamus. How they will come? They will come through the axons. Through their axon, they will travel along the neurons, and they will come and they will start stimulating secretion of the hormone from the pituitary gland, right? So now how they are going to act on pituitary gland, that is interesting point, because in human body, pituitary gland or pituitary lobe is having anterior and posterior lobe. So here, as I said, pituitary gland, they are having anterior and posterior lobe. They are having anterior and posterior lobe of the pituitary, right? So anterior and posterior lobe of the pituitary will be present. So here I would like to show you one simple diagram so that we can understand more clearly. Suppose I am showing you this is the hypothalamus, right? So I am showing you this is the hypothalamus, right? This is the hypothalamus, right? We are seeing this is the hypothalamus. As I said, hypothalamus, they are having neurons. So suppose I am showing you these are the neurons. These are the neurons and these are the nerve endings, right? So through the axons, as I said, transport will be through the axons. So these are the axons, right? So axonal transport will be there from the hypothalamic neurons to the hypothalamic. So these are the hypothalamic neurons. Through the neurons, the axons are transmitting, and now you can see there is a two parts of the pituitary. One is anterior part of the pituitary, and second is posterior part of the pituitary, right? So what I'm showing you here, this is the anterior pituitary and this is the posterior part of pituitary gland, right? So anterior and posterior lobe of the pituitary gland. So what I'm showing you here, it is the pituitary gland. Anterior and posterior pituitary gland is shown in this picture, right? So anterior pituitary, how they are going to secrete hormones under the influence of hypothalamus. So anterior pituitary, these nerve endings will be combining with portal circulatory system. So what I am showing you here with portal circulatory system. So it is portal circulatory system. So what I am showing you here, it is a portal circulatory system, right? So whatever hormone or whatever secretions are coming from the hypothalamus, they will reach to the anterior pituitary, and in anterior pituitary it will be taken up by the portal circulatory system, and from this portal circulatory system there will be release of pituitary hormones. So release of pituitary hormones, right? So anterior pituitary is under the control of the axons and portal circulatory system, but posterior pituitary, how it is unique. In posterior pituitary there is no portal system, there is no portal circulatory system. Here in posterior pituitary, hypothalamic neurons, their terminal ending, so as I said, their terminal ending, so this is the terminal ends. So terminal ends of axons, right? So terminal ends of axons will be releasing hormones, right? So they will be releasing hormones by terminal ends of the axons. So these terminal ends of the axons, which I'm showing you here, these terminal ends of the axons, which I'm showing you here, these terminal ends of the axons are also known as herring bodies. These are called as herring bodies, right? So these are known as herring bodies. So now you can see that how hypothalamus is associated with hormone secretion, right? So when we are seeing, as I said, hypothalamus will be having neurosecretory cells which will transport the hormone through the axons of the neuron, and axons in anterior pituitary will come in contact with portal circulation, and then they will start releasing pituitary hormones. Whereas posterior pituitary, axons will be coming to the posterior pituitary, axon terminal endings will be forming a localized herring bodies. This was the all India question, herring bodies, right? So herring bodies, where you will see herring bodies? In posterior pituitary, right? So now you can see in posterior pituitary we can see herring bodies. What are herring bodies? These are the terminal ends of the neurons, right? So terminal ends of the hypothalamic neuron. So you can see hypothalamic neuron terminal ends forming herring bodies which will be releasing posterior pituitary hormones. So this is how we can see anterior lobe and posterior lobe. So now you can have a very clear cut idea कि when this axonal transport is going to the pituitary gland, in anterior lobe it is involving portal circulation, right? Whereas posterior lobe, they are involving herring bodies, right? Posterior lobe, they are involving herring bodies, which are the terminal ends of the axons of the hypothalamic neurons, right? So that is the important point about the, and that basic knowledge we should know that how hypothalamus is controlling the hormone secretion. So hypothalamus is controlling hormonal secretion by two methods, right? Anterior pituitary through the portal circulation, and posterior pituitary by hypothalamic nerve endings which are known as herring bodies, right? So anterior and posterior lobe of the pituitary. So now you can see anterior and posterior lobe of the pituitary. So if you study pituitary gland, right, if you study pituitary gland, they have, so pituitary gland, as I said, they are having two lobes, anterior and posterior, anterior lobe and posterior lobe. Anterior lobe is also known as adenophysis. Anterior lobe is also known as adenophysis. Posterior lobe is also known as neurophysis, right? So neurophysis, as I said, herring bodies will be present in posterior lobe, right? So as I said, anterior lobe circulation of hormone is neurons and portal circulation. Whereas posterior lobe, it will be through the terminal endings of the neurons, which are called as herring bodies, right? So herring bodies, terminal ends of the axons, which kind of hormones will be present into them? So they are a storage of, so herring body is a storage of which hormone? So your answer will be antidiuretic hormone, ADH, and second is oxytocin, right? So ADH and oxytocin will be stored inside the herring bodies, right? So herring bodies, they have substances which will be containing hormones called ADH and oxytocin. That is the posterior pituitary. Coming to the anterior pituitary, what are the substances which will be present in anterior pituitary? Anterior pituitary cells are heterogeneous. Heterogeneous means there are two types of cells, right? There are two types of cells which will be present in anterior pituitary, right? One will be acidophilic and another will be basophilic. So what are these two types of cells in anterior pituitary? Acidophilic and basophilic, right? Acidophilic cells and basophilic cells. So acidophilic and basophilic cells, these are the two types of cells present in anterior pituitary, right? So anterior pituitary is heterogeneous cell, acidophilic, eosinophilic, basophilic means blue color. This is pink color. So what are these pink color cells? Right, so here, what are the cells which will be present in acidophilic areas? These are growth hormone secretors, right? Growth hormone secretors, they are also called as somatotrophic cells or somatotrophs. Somatotrophs, right? So growth hormone secretors, somatotrophs, and second will be prolactin secretors. Prolactin secretors. Prolactin secretors are also known as lactotroph. Lactotrophs, right? So lactotrophs and somatotrophs. So acidophilic cells are GH secretors, growth hormone and prolactin. So these are two things which will be present in acidophilic, growth hormone secretor cells and prolactin secretor. Growth hormone secretor cells are called as somatotroph. Prolactin secretors are called as lactotroph. So these two are present in acidophilic. Come to the basophilic part. Three types of cells are present in basophilic, which we will remember like this. Base is fat. Mnemonic is, see this mnemonic which I am going to use here is base is fat. Base is fat, right? So that we can remember them, right? So there are three hormone secretor cells. F for FSH LH, A for ACTH secretors, T for thyrotroph secretor cells, right? So these are three types of secretor cells which I am going to write here, right? So what are these things? In basophilic areas, these cells are, number one is FSH LH secretors, right? So FSH and LH secretors are present in anterior basophilic cells, right? So these are also called as gonadotrophs, right? So these are also called as gonadotrophs, right? So gonadotrophs will be releasing gonadotropin like FSH, LH, right? Second is ACTH secretors. ACTH secretors. ACTH secretors are also known as corticotrophs. Corticotrophs, right? So ACTH secretors are corticotrophs, and then comes T for TSH secretors. TSH secretors. TSH secretors are also known as thyrotroph. Thyrotrophs, right? So as I said, these are the three types of basophilic cells in anterior pituitary, right? So these are the simple basic introduction about the pituitary gland, right? So as I said, pituitary gland, anterior, posterior pituitary. From where they are getting circulation of the hormone? Hypothalamus. Anterior pituitary via portal circulation, posterior pituitary via terminal endings of the neurons of the hypothalamus, which are called as herring bodies. Posterior pituitary will be having ADH oxytocin. Anterior pituitary, they are acidophilic basophilic cells. Acidophilic cells are growth hormone secretors, prolactin secretor. Basophilic are three cells: fat, FSH, LH secretors, then ACTH secretors, then thyrotroph secretors. So this is how we are going to have a basic knowledge about the pituitary gland and hypothalamus. Now we will discuss about the pathologies of the pituitary gland. So now we are going to see what are the pathologies of pituitary gland, right? So pituitary gland, there are two pathologies we know. Either they will be lesser or they will be higher secretion. So hyper and hypopituitarism. So we are going to discuss in pituitary gland, there are two things: hypopituitarism and hyperpituitarism. So there are two things: hypopituitarism and hyperpituitarism. So hypo and hyperpituitarism, right? So these are the two things, right? Pituitary gland hypopituitarism and hyperpituitarism. What is the condition? Means what is the criteria to say that there is a hypopituitarism? When there is a destruction of pituitary gland beyond 75% of the total areas. So more than 75% of pituitary gland has been damaged, that will give rise to hypopituitarism. So remember this point for exam point of view, right? More than 75% of pituitary destruction will be responsible for hypopituitarism, right? So more than 70%, 75% of pituitary gland will be damaged, that will be giving rise to hypopituitarism. So in hypopituitarism, what is the most common cause? So most common cause of hypopituitarism is pituitary adenoma, right? So here we have to remember that most common cause of hypopituitarism. So remember, most common cause of hypopituitarism is pituitary adenoma. Pituitary adenoma, right? So adenoma, pituitary adenoma is the most common cause of hypopituitarism, right? So this is the most common cause, and when hypopituitarism is going on, so you know that there are so many hormones there. So which hormone will be earliest decreased in hypopituitarism? So earliest decrease will be earliest hormone affected. When examiner will ask you this question, so remember, growth hormones are earliest affected, right? So your answer should be growth hormones are earliest affected in hypopituitarism, right? So this point we have to remember. Which hormone will be first affected in hypopituitarism? Growth hormone will be first affected in hypopituitarism. Growth hormone will be first affected in hypopituitarism, right? Now we will see what are the causes of hypopituitarism, right? So what are the causes of hypopituitarism, right? So causes of hypopituitarism, number one is surgery, irradiation, right? So surgical resection, irradiation, and one syndrome which is called as Sheehan syndrome. Third one is Sheehan syndrome. So what is Sheehan syndrome? It is pituitary necrosis because of the hemorrhagic shock after the childbirth. So postpartum pituitary necrosis, right? So what is Sheehan syndrome? Sheehan syndrome is postpartum pituitary necrosis. So postpartum pituitary necrosis due to hemorrhagic shock, right? So postpartum pituitary necrosis due to hemorrhagic shock. Due to hemorrhagic shock is called as Sheehan syndrome. So Sheehan syndrome is another reason for the hypopituitarism. So surgery, irradiation, Sheehan syndrome, and empty sella syndrome. Another important cause of hypopituitarism is empty sella syndrome. This is very important to remember. Empty sella syndrome. Empty sella syndrome is because of pituitary destruction, right? So empty sella syndrome is due to pituitary destruction, right? So because of pituitary destruction, there will be hypopituitarism. So now you can see that. What are the important point about hypopituitarism? Pituitary parenchyma should be damaged more than 75%. Most common cause will be pituitary adenoma. Other causes are surgery, radiation, Sheehan syndrome, which is a postpartum pituitary necrosis in a hemorrhagic shock, empty sella syndrome, where pituitary will be having destruction. And then we will see what will be the clinical feature in, what are the clinical features of hypopituitarism, right? So as you can see that, what are the pituitary gland component, right? Gonadotropin, right? Thyrotropin. So when all these things are decreased, what will happen, right? What will happen? So this patient will be having growth failure, right? Because growth hormones are decreased, so growth failure will be there. Growth failure will be there because gonadotropins are decreased, so patient will be having amenorrhea, infertility, right? So patient will be having infertility or amenorrhea, right, in females. So growth failure, infertility, amenorrhea. If thyroid releasing hormones are decreased, then what will happen? Hypothyroidism. So all these are hormonal impact of hypopituitarism. Hypothyroidism, right? So in hypopituitarism, growth failure, infertility, hypothyroidism, these are the basic clinical findings we will observe, right? Now coming to the hyperpituitarism, excessive release of the pituitary hormone is called as hyperpituitarism, and most common cause of hyperpituitarism is also, most common cause of hyperpituitarism is again pituitary adenoma. So here also same reason, pituitary adenoma. We will discuss later on what are the pituitary adenomas because it is important, right? Pituitary adenoma is the most common cause of hypopituitarism also and hyperpituitarism also. So what is the pituitary adenoma which will be causing hyperpituitarism? So this pituitary adenoma can be microadenoma and it can be macroadenoma also. So micro and macro, these are two adenomas we will be seeing, right? Microadenoma, what is the criteria? That was the older All India question. Their size will be less than 1 centimeter. Size is more than 1 centimeter will be considered as macroadenoma. So microadenoma size will be less than 1 centimeter. Macroadenoma size will be more than 1 centimeter. So overall, what I want to say that 1 centimeter is the criteria for deciding pituitary adenoma to be micro or macroadenoma. Now the question is, our important point to understand here is, microadenoma will be functional. They will be releasing hormones and causing basic of the pathology. Macroadenoma is usually silent. Hormonal secretion will be not from them. So that is why I am saying usually silent. So this point we have to remember. Microadenoma is usually functional. So microadenoma is usually functional, whereas macroadenoma is usually non-functional. So that point we have to keep in mind. We have to remember that even though they are larger, but they are non-functional. Even though they are smaller, they will be functional. They will be causing problem, right? So hyperpituitarism, microadenoma, macroadenoma, functional and non-functional, right? So micro is functional, macro is non-functional. So next we are going to discuss about the pituitary adenoma, because we have seen pituitary adenoma is the common cause for microadenoma, for hypopituitarism also. and hyperpituitarism also. So now we are going to discuss detail about pituitary adenoma. So now we are going to discuss about pituitary adenoma. So we are talking about pituitary adenoma is most common. So what are the pituitary adenomas component they will be having? They will be having prolactinoma, they will be having growth hormone adenoma, and they will be having ACTH adenoma. So there are three types of pituitary adenoma. So now we are going to discuss these three types of pituitary adenoma. As I said, there are three types of adenomas. Prolactinoma, number one, prolactinoma. Then second one is growth hormone adenoma. And third is ACTH adenoma. So now we can see there are three types of pituitary adenoma we are going to discuss, right? Prolactinoma, GH adenoma, ACTH adenoma. So out of these three, now the question is, out of these three types of pituitary adenoma, which is most common? Which is most common? Prolactinoma is most common type of pituitary adenoma. So that point we have to keep in mind. Prolactinoma is most common type of pituitary adenoma. So most common type of pituitary adenoma is prolactinoma, right? So because of prolactinoma, what will happen? There will be more secretion of the prolactin hormone. So in this patient, there will be excessive secretion of the prolactin hormone. Excessive prolactin hormone secretion will be there, right? This increased prolactin secretion is also associated with suprasellar mass effect. Increased prolactin secretion is also associated with Stark effect. They are also associated with Stark effect. So examiner may ask you this question, what do you mean by Stark effect? What is the meaning of Stark effect? So what happens? Suprasellar mass in the brain, they inhibit hypothalamus. So what happens in Stark effect? As I told you, suprasellar mass will inhibit hypothalamus, right? So suprasellar mass will inhibit hypothalamus, and in hypothalamus also specifically it will inhibit prolactin inhibitory signals, right? So now you can see that. What is the problem? Suprasellar mass is inhibiting hypothalamus. Hypothalamus will inhibit prolactin inhibitory signal. So as a result, what will happen? There will be more prolactin secretion. So because of this, there will be increased prolactin secretions, right? So that is what we had begin, right? So we had begun with prolactin secretion will be more. Why there is a more prolactin secretion? Because of Stark effect. What is a Stark effect? Suprasellar masses, they will inhibit hypothalamus. What is the function of hypothalamus? Hypothalamus, they will send inhibitory signal for stopping the prolactin, right? So that inhibitory signal of hypothalamus is inhibited. So they have been inhibited their prolactin inhibiting signal, and because of that there will be more prolactin secretion. And because of more prolactin secretion, what will happen in prolactinoma? Because of more prolactin, if you look at their clinical feature, they will be having galactorrhea, right? So because of more prolactin secretion, they will be having galactorrhea, means excessive milk discharge. And second, this patient will be having amenorrhea and infertility. So these are the important points about the prolactinoma, right? So galactorrhea, amenorrhea, infertility. So these are the findings which we will be seeing in case of the prolactinoma, which is the most common cause of anterior pituitary adenoma, right? So we have seen about prolactinoma. Now we will see about GH adenoma, growth hormone adenoma. In this type of pituitary adenoma, there will be increased secretion of growth hormone. Increased secretion of which growth hormone? These are insulin growth factor 1, right? So number 1 is insulin growth factor 1. Insulin growth factor 1, right? So IGF-1, number 1, insulin growth factor 1. There will be increased secretion of the insulin growth factor 1 in growth hormone adenoma, and there will be increased secretion of the somatomedin C. Somatomedin C, right? So these are the hormones which will be excessively released from the growth hormone adenoma. Because of excessive release of these two hormones, what will happen? There will be excessive growth. And how this excessive growth will be reflected, right? So these excessive growth, they will be causing increased growth. This excessive growth factor will be reflected as gigantism and acromegaly. So excessive growth will be reflected as gigantism and acromegaly, right? So what is gigantism and acromegaly? What is the difference? Gigantism occurs in pediatric patient, right? So it will be seen in children, right? So this will be seen in pediatric patient. So these are pediatric patient and they will be having tall stature. So abnormally tall stature will be there because it occurs before epiphyseal fusion, right? So they will be having tall stature because it will happen before epiphyseal closure. Before epiphyseal closure, that is why they will be having tall stature, right? So patient, because this growth will happen before the epiphyseal closure, that is why they will be having abnormally tall stature. Acromegaly, it will happen in adult after the epiphyseal closure, so it will be seen in adults. And in this patient you will see they will be having larger size of the head, so larger head, hand, feet, mandible, right? So all these things will be larger in this patient, right? So larger head, hand, feet, mandible, so all these things will be large, but stature will be not very high because it happens after the epiphyseal closure, because it is seen in adults. So acromegaly will be having this kind of finding, right? So growth hormone adenoma is because of insulin growth factor 1 and somatomedin C. What will happen because of them? There will be excessive growth. In children it will be reflected as a gigantism, tall stature, and in adults it will be reflected as a acromegaly, right? In growth hormone adenoma, because of increase in growth hormone, they will be prone to, so they will be having increased incidences of diabetes mellitus. So they may have diabetes mellitus. So what I can say, they are also associated with, I should say that growth hormone adenoma is also associated with diabetes mellitus, hypertension, muscle weakness, right? So these are the things we can see in case of growth hormone adenoma. Here it is very important to understand, because these are important questions in exam. Diabetes mellitus is associated with hormonal conditions. So answer will be yes. In growth hormone excess, we will find diabetes, right? So remember, diabetes mellitus is also associated with other endocrinopathies like growth hormone adenoma or pituitary adenoma, right? Third is ACTH adenoma. So in this, there is a increased amount of ACTH secretion, right? And this ACTH secretions will be causing disease which is called as Cushing's disease, right? So this is called as Cushing's disease. Excessive amount of ACTH release will be leading to Cushing's disease, right? This excessive amount of ACTH secretion can be because of the ACTH adenoma secondary to the adrenal resection. Right here, I want to explain you one important syndrome associated with ACTH adenoma, right? That is called as Nelson syndrome. Nelson syndrome. Right, so that is important point which is associated with ACTH adenoma. So what is Nelson syndrome? It is actually ACTH adenoma only. But pathology is because of resection of the adrenal gland. So try to understand, which I will explain you. See what I'm writing here. It is hypothalamus, right? Hypothalamus, they will be secreting corticotrophs, which will be going to the pituitary. Pituitary will be sending hormone to the adrenal gland, right? And then they will be performing function. So when adrenal gland secretion is there, so whatever secretions are produced from the adrenal gland, they will send inhibitory feedback to the pituitary and hypothalamus. So as I said, inhibitory feedback. So inhibitory feedback is given from the adrenal gland. Now suppose that if this adrenal gland has been resected, what will happen? If adrenal gland has been resected, what will happen? This kind of inhibition will be lost. So this negative feedback from the adrenal hormones will be decreased to the pituitary and hypothalamus. So if this has been decreased, what will happen? There will be excessive amount of corticotrophs. This corticotroph will be causing more pituitary activation, and this will be causing ACTH adenoma. So what is Nelson syndrome? Nelson syndrome is ACTH adenoma due to adrenal gland resection. Right, so we have removed the adrenal gland. After removal of the adrenal gland, this negative feedback has been lost. There will be more ACTH secretion, there will be more corticotroph secretion from the hypothalamus. Pituitary will be having more ACTH, and that will transform them into ACTH adenoma. So that is the point we have to keep in mind. What is Nelson syndrome? ACTH adenoma secondary to the adrenal gland resection. So these are important points about the hypo and hyperpituitarism and various types of pituitary adenomas. Pituitary gland tumors, if you see pituitary gland tumor, right? So as I said, pituitary gland tumor can be adenoma, which is a benign tumor, right? And pituitary gland tumor can be carcinoma. So as I said, pituitary gland tumors can be adenoma or carcinoma, right? So we should always remember adenoma is more common, right? So when we are talking about the difference, adenoma is more common than carcinoma. So what is the distinguishing feature? Means how we can say that it is adenoma or carcinoma. So it is mere presence of the metastasis. So there are some endocrinological tumors. So pituitary adenoma, when there is no metastasis, that will be called as adenoma. So adenoma means there will be no metastasis, and when you find there is a presence of metastasis, that will be considered as carcinoma. So that point we have to remember. Adenoma versus carcinoma. If you find metastasis, that will be called as carcinoma. If you find no metastasis, that will be called as adenoma. So these points we have to keep in mind. Now we will see about the posterior lobe of the pituitary gland, which is also known as neurophysis, right? So neurophysis, where herring bodies will be there, and as I said, in neurophysis, the terminal ends of the axons are called as herring bodies. Herring bodies are storage for two important posterior pituitary hormone, that is oxytocin and ADH, right? So these are the two hormones, oxytocin and ADH, right? So oxytocin, we all know that oxytocin is for milk secretions and for uterine muscle contraction, right? So uterine muscle contraction, oxytocin, and ADH. Now coming to the ADH, what is the function of ADH? Antidiuretic hormone. Antidiuretic hormone, which is also known as vasopressin, right? So ADH or vasopressin, their basic function is to increase renal water absorption, right? So increase renal water absorption. So ADH hormone normally, when they functions normally, there will be increased renal water absorption will be there. But what happens in case of ADH deficiency? ADH deficiency is called as diabetes insipidus. So this is diabetes insipidus. What happens in diabetes insipidus? As I said, in diabetes insipidus, there will be decrease in ADH hormone, right? So because of decrease in ADH hormone, so normal ADH, as I said, they are required for more water absorption from the kidney. So there will be less water absorption from the kidney, right? So because of decrease in ADH, there will be decreased water absorption. There will be decreased water absorption from the kidney. Because of decreased water absorption, what will happen? There will be more sodium concentration. So there will be hypernatremia. There will be hypernatremia. This hypernatremia will be causing polydipsia and polyuria. So this patient will be presenting with polydipsia. They will be having more thirst. They will be having more water intake, and because of more water intake, they will be having more urination. So polydipsia and polyuria. So polydipsia and polyuria will be the basic presentation of the diabetes insipidus, right? So in case of diabetes insipidus, so now you can see that what will happen in diabetes insipidus, there is a deficiency of ADH secretion. Because of that, there is a low water absorption in the kidney, and that will increase the sodium absorption, hypernatremia. There will be more sodium, more hypernatremia, which will be leading to polydipsia and polyuria. So what will be the reason? What are the causes of diabetes insipidus, right? So now we'll see what are the causes of diabetes insipidus. So causes of diabetes insipidus are head injury, right? So usually patient will be having head injuries, or maybe due to the inflammation of the brain, right? It can be because of tumor also, right? So head injury, inflammation, tumor, all these are the reasons for the diabetes insipidus, where there will be decrease in ADH. There is another interesting condition that is called as SIADH. There is a second important condition which we should remember, is called as SIADH, syndrome of inappropriate ADH secretion. This is called as syndrome of inappropriate ADH secretion. In SIADH, syndrome of inappropriate ADH secretion. So what happens in syndrome of inappropriate ADH secretion? In this patient, there will be excessive amount of ADH secretion, right? There will be excessive amount of ADH secretion. If there is more ADH, there will be more water reabsorption. More water reabsorption in kidney, right? So because of more water reabsorption in kidney, there will be dilutional, and there is dilutional hyponatremia. So we can say that there will be hyponatremia. So what will be the presentation of this patient? When you will see clinically, this patient will be showing oliguria, right? So less amount of urine coming, oliguria. There will be cerebral edema. So oliguria, cerebral edema. So oliguria, cerebral edema, and neurological deficit. Right. So these are the things which we are going to see in case of syndrome of inappropriate ADH secretion. What is the reason? What is the reason for this? They are usually associated with paraneoplastic syndrome. They are usually associated with paraneoplastic syndrome. Paraneoplastic syndromes. So they are usually associated with paraneoplastic syndromes. So most commonly they are associated with which cancer? So now we have to understand SIADH is most commonly associated with small cell cancer of lung. Right, so small cell cancer of lung is most commonly associated with SIADH, where ectopic ADH will be released, right? So these are important point about the posterior pituitary.